Well, welcome everyone. We're super excited to have you to Agricultural Worker Health 102. Some of you may have participated in our Ag Worker Health 101. There's a little bit of similar content, but in this one, what we really like to do is to dive deeply into resources that are available to you. So we're going to be spending some time doing a broad overview of the farm worker population, but more time really looking at resources. And one of the big resources available to you is the Farmworker Health Network. And if you're not familiar with who we are 6 national organizations that are funded, funded partially through HRSA to provide training and technical assistance to community and migrant health centers throughout the United States. And we're going to be going into a lot more detail about each organization and the resources that we have for you in the latter part of this conversation. So looking at the workshop components, what we're going to be looking at, we're going to do an overview of agricultural worker health and safety concerns, look at service delivery innovations to give you some ideas of what has happened in a variety of different locations and hopefully spur some of your thinking about how to deliver quality care to this population. And then, like I said, we're going to be diving into resources for health centers to address issues for agricultural workers and their families. So we're going to do a Zoom poll to start with, and just want to get a better idea of who you are and how many years you have working in migrant health. I'll give you all a chance to respond. Okay, so interestingly, it makes sense that the vast majority of you, 71%, have 0 to 3 years working in migrant health. So we're super glad to have you here, and hopefully we'll provide you with some information that will really benefit you as you move forward in this really rewarding career. So we're going to start out with, we really think that in order to understand where we are right now and why we have gotten to the place where we are right now, you really need to understand the system of labor that has occurred in this country over this, the latter part of this last century and a half or so. And it really does impact people today, what happened, 30, 50, 80, 100 years ago. So thinking about the events that have led up to the migrant health program, and you think about agriculture in this country, and in the 1850s, there was advances in crop production. So that allowed refrigeration. So lettuce could be transported from, Nebraska to New York City. And that the move away, the very sort of beginnings of a move away from a family farm that was just subsistence to feed your family moved into a more viably economic endeavor, and it increased the demand for a migratory and seasonal labor force. And then you look at the World War I time period, there was an Immigration and Nationality Act of 1917 as the US became more concerned about about immigrants and unfortunately people, coming from different places and wanting to control some of those immigration patterns. The 1930s was the Dust Bowl and the start of domestic migration. Many people are familiar with Grapes of Wrath and that whole discussion of Dust Bowl migrants who left places in the middle of the country, Oklahoma, Texas, other places, and moved particularly to the West Coast to try and find work in agriculture or something else. So in 1937, the Farm Security Administration was established. And in 1942, there was the Bracero Treaty, which many of you are probably familiar with, but it really involved the recruitment and employment of Mexican citizens during World War II. And then those people, as soldiers came back from World War II, those people, many of them were deported back to Mexico. But we see echoes of the Bracero program in some of the policies that are enacted today. And then in the 1950s, the Public Health Service established the Migrant Health Unit, which led to, and some of you may have seen this, but a number of you haven't. It's really worth taking a look at. You can search for Harvest of Shame. It came out in 1960. It was a documentary about farm workers. It was narrated by Edward R. Murrow, and really highlighted many of the challenges faced by agricultural workers in this country. So in 1962, the Migrant Health Act was signed into law by President John F. Kennedy. And interestingly, the Migrant Health Act came before community health. So the migrant health centers were actually the foundation of the community health clinics that followed not long afterwards. But we find this a lot in migrant health. Because I think that well, I have my own theories. I'm sure everyone else has theories that they could put forth. But I think that in general, there are dedicated people who are concerned about the health of agricultural workers, or become concerned when they become aware of what's happening. And those dedicated people, I think, tend to be very innovative. So I'm talking to all of you. I think you're probably all have ways in which you're very innovative and think outside the box, and think about different ways to approach a population that may not be well served by a standing established healthcare setting. So anyway, that's my own little soapbox. But in 62, the Migrant Health Act was enacted. And then in 1970, there was a reauthorization of the Migrant Health Act, and it created the National Advisory Council on Migrant Health, which still exists to this day. It's a statute, and it's federally mandated. And they also added seasonal workers. So for those of you who are unaware of that definition, a migrant worker is someone who moves away from their home for the purposes of engaging in agricultural work in different locations. And seasonal workers also work in agriculture, but stay in the same location and are employed on a seasonal basis. Okay, so then after, well, starting in 62 and 75, looking at some legislative actions, there's the Migrant Health Act, which we talked about, and then the Public Health Service Act, which established Section 330, which are community health centers, and that was part of the Public Health Service Act. In 83, there were some basic labor protections established under labor contractors. And then in 87, there's the field sanitation standard, which required agricultural workers to provide water, toilets, and hand washing facilities in the field. In 92, there was an update to the worker protection standard, which set minimum standards for protecting farm workers from pesticide exposure. And in 96, there was a Health Center Consolidation Act, which moved the migrant health centers, homeless health centers, public housing, and community health centers all under Section 330 authority under HRSA and the federal funding purpose. So that it didn't really change a lot in terms of funding, but it did consolidate that. So so now migrant health is a subsection under Section 330. In 2010, the ACA, the Affordable Care Act, was enacted, which really did expand services and access to a number of farm worker patients, depending to a certain extent on the state in which they were working. But it did add additional capital for health centers as well. And then in 2017, there were worker protection standard revisions. But a piece that is super important to understand, and you may have heard about farm worker exceptionalism. I'm just peeking ahead for a second. Okay, no, we don't have it in here, but I wanted to let you know sort of the basis of, so farm worker exceptionalism, what that refers to broadly is this notion that farm workers are left out of a number of labor protections that other workers in this country are afforded. And that system that allowed those agricultural workers to be excluded is really based in the essentially racism and sort of economics that occurred starting in the, well, long before 1930, but in 1930, in the 1930s, President Roosevelt enacted a number of labor protections, and this was after they had had a number of issues with labor, with people working in really horrendous conditions and that were exposed in factories and other places in the Northeast, and other places. But in order to get the Southern Democrats on board, they excluded farm workers, which at that point were largely low-income African-American workers. They excluded farm workers from those protections. And at that point, the South was still very agricultural and depended on agriculture for their economic engine. So farm workers were excluded, agricultural workers were excluded in order to get those Southern Democrats to sign on to this legislation that protected workers overall. So some of the things that farm workers are excluded from. So the Fair Labor Standards Act, which is the piece that that President Roosevelt signed in 1936, I believe, they excluded child labor protections for farm workers. So even today, and many of you may know this, children as young as 12 can work in the fields. And they also excluded agricultural workers from overtime protection. And there's been some work in some states, notably California, to work on this overtime issue and to bring agricultural workers into protections of overtime. But in many states, it doesn't exist. In addition, there were restrictions on workers' compensation and minimum wage for agricultural workers. And then there are few OSHA standards to protect farm workers. There are some. So there's the Field Sanitation Standard of 1987, but that only applies to farms with 11 or more workers, or farms that provide housing to agricultural workers. So there are a number of OSHA standards that still do not apply. And the other piece that is left out, it's not in the slide, but the other piece that's important to know is OSHA is supposed to protect workers, but the EPA is responsible for pesticides and pesticide exposure. And so you have the EPA, that is, the Environmental Protection Agency, that is both regulating pesticides and approving pesticides, and working with the pesticide industry to do that. They do that piece of it, and they're also supposed to be protecting workers from exposure, either via direct spraying or drift or other things. So there's an inherent conflict of interest in the EPA piece of it, but it's also important to know that the EPA is what regulates pesticides. OSHA does not regulate pesticides. So at this point, I'm going to turn it over to my colleague, but want to know, do you have any questions at this point? That's sort of a lot of information, but we feel like it's important to understand some of the underpinnings of what happens today. And you can we'll keep an eye on the chat for questions, and also in the Q&A, and we'll respond. I'm going to turn it over now to Liam, I believe, who's discussing. I couldn't remember which one of you. I'm turning to my colleague Liam from Health Outreach Partners, who are going to talk about health issues for agricultural workers.
Yeah, thank you, Jillian. Thanks for that overview of the agricultural worker health world, especially the migrant health centers and how the community health center program came to be. In terms of the chat and the questions, I've seen a few requests for materials in Spanish, especially presentations in Spanish. So, I apologize that we're unable to offer this today in Spanish. Gladys Carrillo from NCFH, she shared some overview webinars that are in Spanish that cover a very similar topic to today. You may notice that this webinar is called Agricultural Worker Health 102. That implies, of course, that we also have Agricultural Worker Health 101, which is kind of the more broad and bigger overview of really the basics of not only the community health center program, the migrant health center program, but also some more about demographics of farm workers and a little more details about their health. And that's what I'm going to be talking about here. And I don't know if you're wondering, with some of my friends and family that don't work in this field, in this area, it may be kind of confusing. Why do we dedicate so much attention to this kind of subset of workers? But there's 2.5 million farm workers in the country, estimated, not to mention 4 million if you include families and dependents. And so that's a big piece of our population in this country. But not just that, it's that everything that's inherent to farm work, both who does the farm work and how that work is done, and the environment and context in which that work is done, that really makes for a lot of unique and special circumstances when it comes to their health, and how those of us that work in farm worker health can actually serve them appropriately. And so we look at the prevention, the management, the treatment of health issues when it comes to farm workers. And we know that there are all of these special circumstances that we have to consider, because they are highly migratory, they do very difficult work, and the context in which they live and the environment in which they live can provide for a lot of health issues and a lot of barriers. And so all of these things not just are what those of us who work in health have to consider, but we also have to recognize that these are distinct social determinants of health, of our living conditions, our occupation, the migratory lifestyle of farm workers. And so the health issues that they face get really magnified and compounded doing this work. So there's a big need for access to care focus. And we have to realize that when we're serving farm workers, it can be a little bit tougher to kind of track their care, connect them to specialty care. And a lot of the focuses that we have to apply to this population may be different from others that you serve. So I mentioned management of health concerns, and one of the reasons that we focus on that is because farm workers have really high incidences of not only infectious diseases, but also many chronic diseases. So things like diabetes, hypertension, cancer, as well as infectious diseases like HIV/AIDS, tuberculosis, asthma. These are things that we see really high incidences of when it comes to farm workers. And that's all not just because of some of the things I mentioned of their social determinants, but that it can be really tough to manage their diseases when it comes to long-term management. Again, access to health insurance is very low in this population. And so first and foremost, availability and understanding of the health system can be a big challenge. The mobile nature and transitory nature of the population can be really tough to track and manage their care when they're going from one place to the next in only a matter of weeks or months. And then also, because of the demographics of this population being largely not speaking English as their primary language, and distinct cultural needs when many are coming from other countries, can make it a lot harder to find not just providers and specialty care, but even some of the kind of frontline staff and the first touch staff to be providing services that are both culturally and linguistically appropriate. And so, that's something that we really have to consider when we're serving this population. And that was never more apparent than during the COVID-19 pandemic, which I should say is not over by any means, but especially in the earlier days and the first couple years of the COVID-19 pandemic, a lot of the challenges and barriers faced in serving farm workers really gets magnified when when we all had to direct all of our attention, our resources to such a big public health emergency. And so some of the challenges that we saw in serving this population during the COVID-19 pandemic it's just like a small example of how difficult it can be to serve this farm worker population. So some of the challenges when we're talking about COVID-19 guidelines, especially in the early days, made farm workers exceptionally susceptible to contracting the disease, as well as overcoming and healing from a positive diagnosis. So the overcrowding in farm worker living conditions made it really tough to social distance, as well as if you were infected, finding a way to isolate. So, getting out of that overcrowded area, but finding another place to be able to isolate those that had tested positive. Access to PPE was a big challenge, and that's something that we see not only every day with the exposure to pesticides, but then when it came to providing PPE for workers in the field and in their living situations, there was really low access in the early days, as well as limited access to testing, treatment, and vaccinations. And then the public benefits that many of us in different sectors and many of the population in the US and worldwide that had access to was very limited when it comes to farm workers, even though we kind of uplifted them as essential in the early days. So things like just accessing information that was up to date, that was in a language that they understood, that was at a linguistic level and an educational level that was easily understood, as well as being eligible for services, either public services that maybe those who were undocumented didn't have access to, or services that were only available to those who had health insurance. And then finally, a lot of challenges related to living conditions. So even if their housing was allowing them to socially isolate, still just transportation to and from the fields might have been in a crowded bus or a crowded van where they might have been exposed. And then some of the fear and resulting from misinformation, and also a kind of a history of discriminatory policies around a lot of people that make up this labor force. There's a lot of fear in accessing healthcare. I know for myself, my first vaccine was at a big vaccination event put on by the National Guard. And so there's a lot of folks in military uniforms and a lot of forms being filled out. And there's a lot of fear around that in this community, as well as just being able to take sick leave and fearing employer retaliation, or just fearing losing your wages by taking sick leave. So a lot of these examples that we saw during the COVID-19 pandemic were just examples of serving them on a greater level. And then we're also seeing a big rise in mental health concerns. And part of this is just a greater awareness of mental and behavioral health concerns. I don't think necessarily it's a brand new thing, but there's been a much larger emphasis on this. And so, we see that just like with many chronic diseases, there's an extra risk and extra high risk for farm workers, that they have higher challenges when it comes to treating and facing their mental health. A lot of them are leaving their families, especially if they're coming from overseas, from another country. And so that separation from families and that isolation that they feel when they're in a new country, maybe don't speak the language. They might be housed with a bunch of other folks that are kind of in a similar situation as them, and really feeling that distance from their families can be a big strain on their mental health. Once they're here, we know that a lot of farm workers face discrimination around, our immigration policies and just kind of the political and social rhetoric that happens. There's a lot of discrimination towards, and a history of discrimination towards this population. I mentioned some of the fears when it comes to COVID-19, and those fears really apply to a lot of things, especially for those that are undocumented or even just perceived to be undocumented. or have family members that are undocumented, where they have a mixed status household, maybe a spouse or a sibling or somebody else in their family is undocumented. Even those that do have documentation may not seek out services, whether it's health services, whether it's public benefits that they are eligible for, or mental health services. And then I've already mentioned COVID-19, but it also had a big strain on folks' mental health, having to isolate, having to, not having the same access to, say, returning home if they migrate within the US or overseas. And a lot of the stigma that came with COVID-19 and those that may have been perceived to be higher at risk or to be spreading the disease. Some of the other big challenges, and one of the greatest social determinants of health that really set this population apart from other vulnerable populations, is illnesses that are related to their housing. So, a lot of farm workers live in kind of a lot of different living conditions. They might be living in labor camps. They might be crammed into small apartments. Some often live in trailers or even in their vehicles. And so, especially for those that do migrate, a lot of times, especially if they're there in a short amount of time, they may just be looking for whatever housing is available and whatever housing is cheapest. So it's common in a lot of these rental units or in these labor camps that they're really poorly maintained. They're dilapidated, they're overcrowded, maybe they're outdated. And because of these high rents and low wages, farm workers are often squeezing as many people as they can into these small units that create really large health risks. Many also have a lack of modern conveniences. So there might still be lead paint on the walls. They might not have adequate indoor plumbing or heating, might not have reliable access to internet or to electricity. And all of this can really lead to exacerbating health issues and greater health risks. So some of the health risks that come with the actual nature of the work itself, we know that farm workers have an exceptionally high health risk. They have some of the highest data, or they have some of the highest numbers when it comes to injuries on the jobs and even deaths on the jobs. It's really one of the sectors that has some of the highest risks. And so these are just kind of all over the place. And so when you think about what types of work farm workers are doing, that really runs the full spectrum. So it might mean that they're working with really sharp tools that, they might be cutting themselves. They might be working in ladders that have a fall risk. They're working outside and sometimes in incredibly high temperatures, or where there is risk with the environment and climate change. And we see that a lot with wildfire smoke, especially in the last several years in really big agriculture areas like on the West Coast and Washington, Oregon, and California, where we're having a lot greater incidences of wildfires. And we've seen some really stark images of farm workers, for example, picking grapes up in Napa with the hills on fire in the background. And so these are impose really difficult and high risks to farm worker health. Just slipping and falling in the fields, or kind of difficult positions that they're put in, such as really bending over all day picking strawberries or other low types of produce. And then also just being outside, there's something as simple as insect, rodent, or snake bites can also pose a big risk. So there are some protections in place, though, as Jillian covered some of these already. They can be really limited. They can leave out big pieces of the population, or they can also just not be enforced nearly enough. So we had the field sanitation standard, and this was implemented by OSHA back in 1987. It just really started the rulemaking process for certain standards, like having drinking water in the fields, having toilets, hand washing facilities, and other good hygiene practices. But as Jillian mentioned, this is only for those that employ 11 or more employees. So even then, this may not be available to all. We also have the worker protection standard that was through the EPA, and because pesticides fall more towards the Environmental Protection Agency, that's all about making sure that there's requirements around safety precautions when using pesticides on farms. Though we know that this isn't always enforced adequately, and that there's still tons of risks when it comes to pesticide exposure. There's some links on here, and when we share the slides out, you'll be able to access these links that kind of break down the different sanitation standards and worker protection standards. And Farmworker Justice has these on maps where you can see it state by state. And then finally, there's more and more, there's newer states, or I should say, there are new protections that are coming in state by state when it comes to wildfire and heat standards, because this is becoming such an increased risk as our climate warms and as we are facing greater natural disasters. And then in the interest of time, I won't go into these too much, but I just want to mention again that Farmworker Justice does have maps that cover not just those standards on the previous slides, but also what kinds of protections when it comes to labor that farm workers have access to. And one of those protections that is newer, of course, is the Affordable Care Act. And in the last 10 years, more and more states have adopted and changed their standards of who's eligible for that marketplace. Unfortunately, such a big proportion of farm workers are still ineligible, mainly due to documentation status. But more and more we've seen have become eligible either for employer-provided insurance, private insurance, and of course, Medicaid, depending on your state. So I invite you to look into this a little bit more with some of the resources that we have available. And now I'll pass it off to Shannon, who's going to talk about service delivery innovations.
Thank you so much, Liam. So I'm just going to briefly go over some of the challenges that you all might experience delivering services to farm worker communities, or that farm workers might experience in trying to seek services. As was mentioned a little bit earlier, obviously this is a migratory group. Oftentimes people are moving around quite a bit, depending on where they're working, what crops they're harvesting, et cetera. And so it can be really difficult for individuals to have a continuity of care with their provider throughout this process. As we learned through Liam's examples, there are a lot of individuals that might have chronic diseases. And so it's hard for them to establish a medical home or to have a consistent medical provider throughout their treatment. And because of the concerns that were also mentioned, individuals might not have health insurance, as Liam just talked about. There might be a little bit of fear around what people can be eligible for, how they're going to pay for services. And so they might not even seek care until there's an emergency, or if they're in an emergent situation. So also one thing that can be really challenging, as you might know, is trying to figure out how you can have communication between different providers, and different migrant health centers, community health centers can be challenging. Each center has their own medical record system. And so it can be hard for people to collaborate and provide this continuity of care throughout somebody's stay here. It's also important to recognize that a lot of individuals and health centers might not be able to provide services in Spanish. And not only are there individuals that speak Spanish, but there's a lot of farm workers out there that speak other indigenous languages, as well as Haitian Creole. And not all healthcare providers are able to provide those services. And again, as Liam mentioned earlier, thinking about not only healthcare providers, but that first contact, those outreach staff, and other things like websites and printed educational materials, prescription information on medications, things like that. They might not be available in the language preferred by the patient. And then other things to consider are that staff are often not trained in the unique needs of this population. So it's important to keep all of these things in mind when you're developing outreach plans and when considering developing a language access plan as well. So I'm also going to go into a little bit about how we might experience challenges with delivery of services in our operations. And so when you're thinking about having patients come in, a lot of individuals, farm working individuals might not be familiar with our healthcare system. They might be coming from a different country who has a totally different system, and thinking about, potentially walk-ins are the norm where they're coming from, right? They're not used to this appointment system. So it's really important to think about that and orient those individuals to our healthcare system, or be more flexible in the kind of appointments we provide. That could be having walk-in appointments, having evening or weekend appointments available. It's also important to consider that the workforce at our health centers are able to provide services when there's a higher demand. So we know that this population is migratory. Individuals might be working in the fields in your areas for 2 to 3 months or even a few weeks. And so thinking about how you might be able to provide more services with a higher demand to individuals that might only be for a brief period of time. And this could be by allowing individuals to have walk-in appointments, or thinking about other unique ways you can reach this group. It's also important to think about transportation. As Liam mentioned, a lot of folks might not have a way to get to a health center, or they might be really far away, or they might have to come in crowded buses, and it's just not something that seems feasible. So considering maybe offering different types of transportation if possible, or other unique ways to help get folks in, or reaching out to them. It's also important to note that healthcare is expensive. A lot of individuals, especially those of you who might be in border communities, folks might wait until they get home to receive services, right? They may not receive any sort of healthcare until there's an emergency. So we need to make sure that the services we're providing are accessible and affordable. And that could be through offering, services at a sliding fee scale for those who are uninsured, or helping individuals sign up for insurance if they're eligible. We just need to kind of get creative and being able to have our services accessible to these folks. And through providing enabling services and outreach services, we might be able to do that. Go ahead to the next slide. So yeah, we're going to talk a little bit more about how can we adapt our services to kind of overcome some of these barriers that I just mentioned. So in order to mitigate some of these barriers, I wanted to discuss a couple different options. So one is making sure that we're providing culturally sensitive education. So information that's appropriate in the language that our communities are speaking, and also ensuring that this information is culturally relevant and also at an appropriate reading level. I know Liam mentioned this a little bit, but I can't stress it enough. It's really important that we're not just following some standards that we might within our organizations, let's say an 8th grade reading level. We want to make sure that we're really understanding our audience and our communities, and if possible, being able to develop materials at a 4th grade reading level. I think we can all benefit from having medical information be a little bit more simplified and accessible, regardless of who our audience is, but really thinking about, how we can reach those farm workers, maybe using more images, things like that. Again, understanding where our communities are coming from, what are some cultural barriers or beliefs that they may have that affect their health. This could be individuals potentially drinking herbal teas to manage their diabetes rather than using other medications or other ways to manage their diabetes. And knowing that and being able to express that to the healthcare team is really important, and being able to communicate about that. Mobility adaptations. So thinking about, again, it's a mobile population, often in rural communities. When individuals leave that area where you're serving them, are they going to be able to continue to get services elsewhere? And are they going to know how to communicate where they are at in their treatment? And so offering copies of medical records could potentially be a way to help those individuals reach out to a new health center and be able to present their records to a provider in order to continue to receive treatment. And then it could also be that, you know, individuals in your area might continuously migrate to another area that has another migrant health center, and communicating with that health center and being able to share records if possible. Again, appropriate service delivery models. So thinking about case management, potentially using lay health promoters, promotores de salud, or community health workers to reach and communicate with this population, providing outreach and enabling services, which I won't get into again. We've kind of highlighted these a few times already. One thing that we haven't mentioned yet is coordinating with schools and work sites. So is your organization able to identify an area that farm workers are working and work with their employers, or identify migrant Head Start programs where you can coordinate services? And then potentially also thinking about mobile units. So we want to create, before I move on, we'll open up a poll real quick and then I'll continue as you guys complete it. But think about if your organization is offering any of these adaptations, or yes or no. Go ahead and open that poll. And I'm going to go on while they answer those questions. So yeah, again, we just want to make sure that individuals have access to care. So orienting patients to our healthcare system, our appointment system. Do we have evening walk-in appointments, weekend appointments, etc. Oh, great. It sounds like a lot of you are already offering these services. So you're already doing great things, and potentially you can take back some more ideas from today's presentation and share them with your teams. One resource I wanted to share with you all, and I'm going to post it in the chat right now, is this really awesome resource that NCFH has, where you can identify where farm workers are at any given time, and you can check and see if there are individuals that are often coming into your area of service, and you can kind of check out there and see how you can better accommodate your services to serve that population. Great. So developing partnerships is really important. I mentioned working with schools. You can work with other community organizations like faith-based organizations, health departments, other community-based services, in order to maximize the resources available to serve and reach this community without necessarily duplicating services. So we really encourage you to do that. And a great example of using community partnerships to serve farm workers is through a voucher program model. I'm not going to go into too much detail here, but it is a great way for some migrant health centers who are not already considered community health centers to serve migrant farm worker communities. So they really provide comprehensive outreach services where they can reach farm workers through providing transportation, interpretation, health education, screenings, and referrals. And many of these voucher programs partner with local organizations to provide health care services through referrals. So just something to consider if you'd want to look up a little bit more information. And with that said, I'll just sort of go into our resources a little bit. As we mentioned earlier, we're the FHN. I represent my MHP Salud, which we are a national nonprofit organization that implements and supports community health worker programs. We also we're celebrating our 40th anniversary this year. We've been serving farm workers. We started in Michigan, expanded to the Midwest, and we actually have programs now in Texas and Florida serving Hispanic and Latino communities through CHW services. So we're also a training and technical assistance provider as some of our other partners on this call. And we can help you sort of work through some, developing a community health worker or promotora program at your organization. If you want information about CHW programming, please do feel free to reach out to me, and I'd be happy to support you or connect you with someone who can do that. We also, I know there was a lot of conversation in the chat for resources in English and Spanish. We have a lot of resources available in our resource library, so feel free to check us out, and that you might be able to use when serving farm worker communities in English and Spanish. And then lastly, we also have just started a YouTube channel, so feel free to subscribe. I know NCFH also has a YouTube channel with great resources and recordings, so go ahead and check us out and subscribe, and you'll be notified when we post more trainings and information. And with that said, I'll pass it back to Jillian.
Thank you, Shannon. I'll also say that MHP Salute is super helpful. If you do not have a community health worker program and you're interested in starting one, the MHP Salute has really great resources for you. So I represent the Migrant Clinicians Network, and our mission is to create practical solutions at the intersection of vulnerability, migration, and health. And our work started with agricultural workers. We have since expanded and work with migrants in a variety of other situations, but agricultural workers remain at the core of what we are doing. We are a clinical network, so we primarily represent clinicians and their work in the community. We have and also a number of resources. We have a number of patient education materials, including comic books and on a variety of subjects. We provide a lot of education to clinicians, including clinical information for outreach and community health workers. So kind of that's some of our intersection with our partners there. We conduct research. We have a bridge case management program, which I'm going to talk about in a second. We do a ton around worker health and safety, and then psychological support for providers. And this became particularly important during the COVID pandemic. And peer networking among providers is really the base. Why MCN started in the 80s was a need for clinicians to network and to share resources and strategies among themselves. Our bridge case management system is called Health Network, and it's free. It's for anyone who is working with patients who may be moving out of their area. And what we do is it's a virtual program, and we have case managers, and they manage the patient to their next location and to their one after that if they need to, and communicate what happened to the patient back to you. So if you're interested in more information about Health Network, it's free to everybody who wants to use it. And we've at this point case managed over 15,000 people, actually all over the world, but much of it within the United States. And this is information about how to connect with us if you're interested in Health Network or anything else that we do. This is a way to communicate with us. I'll put my coworker's email in the chat if you're interested in that. And then Health Outreach Partners, turning it back to Liam.
Yeah, and we'll have our contact info at the end as well. So if this is going fast, you can reach out to any of us. So Health Outreach Partners, all of the different organizations kind of fit a different niche, and we are everything that is outreach and access to care. We have a really strong focus on health equity, and we've been around since 1970. So really in the last 23 years or so, more in this national model. And on the next slide, we have our website. You can find all of our resources. We have a lot of written resources. We have webinars, our blog, articles. So you can go to the next slide, and I'll type our website in the chat, which is outreach-partners.org. But on the next slide, I thought I'd just mention a couple opportunities that are coming up, because we have a few webinars over the next month. There's a topic of structural competency, which talks about some of the policies, the institutions, and the history of why some of the social determinants are the way they are, why some of the disparities exist, not only for farm workers, but for all vulnerable populations. And then we have also a webinar about diabetes prevention for the whole family. That's with MHP Salud, coming up on June 8th. And then another one around interventions to address structures, especially using community partnerships. And I'll just mention NAC, so the National Association of Community Health Centers. They're really, they're the largest of the national training and technical assistance partners. And their mission is to promote efficient, high quality, and comprehensive healthcare that's accessible for all. And so they are really the ones that have a ton of resources when it comes to community health centers, and really are a leader not only in providing training and technical assistance, but also on a policy and advocacy level when it comes to advocating on behalf of community health centers. And so on the next slide, you'll see some of the different trainings and technical assistance they offer. And they also oversee and administer the Health Center Resource Clearinghouse, where you can find resources from all 21 of the training and technical assistance partners, including those of us hosting this webinar. I'll pass it to Alexis for Farmworker Justice.
Hi, everyone. My name is Alexis Guild, and I am with Farmworker Justice. And we are pretty multifaceted. So we engage in advocacy, as well as litigation, training and technical assistance, coalition building, public education. And we work on a variety of issues that impact farm workers and their living and working conditions. Next slide, please. And we have a lot of resources for various audiences, including issue briefs and fact sheets. We also have training of trainer curricula and a wide range of materials for workers in multiple languages, including English, Spanish, Haitian Creole, and Indigenous languages. And we also have resources on our website, as well as we also have a YouTube channel, so I can share that in the chat as well. And the topics for our resources range from health insurance to medical legal partnerships to climate change, heat stress, workers' compensation, and other issues that impact farm workers. And with that, I will turn it over to Gladys to talk about NCFH.
Hi, everyone. I'm here representing the National Center for Farmworker Health, and we are one of the organizations that are part of the FHN. We are a nonprofit in Buda, Texas, and our mission is to improve the health of farm worker families. And you can check out all of our social media channels there. But we offer a variety of different resources and services. Here are some that we do offer. I think Shannon already shared the data dashboard. So we have a lot of research and population-specific data, fact sheets, patient health education resources. We have different resources available in English, Spanish, Haitian Creole, and some COVID-specific items in different Indigenous languages as well. We have some different workforce development and learning collaboratives available, as well as conferences like our regional stream forums and governance trainings and strategic planning. So be sure to check us out.
And just to wrap up, the final resources, of course, the Health Resources and Services Administration, who not only funds us, but funds all of the federally qualified health centers, many that you represent. They have a ton of materials and resources geared to health centers and to patients on their website. And they're just, we are representing the Farmworker Health Network, so the 6 organizations that are funded to serve the migrant health population, but there are a ton of other national training and technical assistance partners that cover different populations that you see here, or special and vulnerable populations. And then on the next slide, there's also several that are about building capacity and workforce. So all of these kind of fit a unique need and a unique population. And so I encourage you to check them out if your health center is interested in increasing their capacity, or if you serve other populations other than farm workers. I mentioned the Health Center Clearinghouse, which is kind of a one-stop shop for all 21 of our organizations where we have resources. And we also post different training and webinar opportunities on this website. So that's healthcenterinfo.org, where you can just find all of this consolidated into one place. And with that, we're right up against time. So as I mentioned, you can reach out to any of us with questions. Those of us that spoke today, you have our information on the screen, and you can check out our websites as well. I know that I can at least stay on a few more minutes for questions, so I hope the rest of us can. But for those of you that are listening to the recording, we're going to be ending our recording here, and I just want to say thank you for joining us today, and thank you for all of you that are joining us live. We really appreciate your participation and attendance. And I'll give Sylvia a moment to end the recording while those of you live can stay with us and think about any questions you have.